Hello, everyone. Welcome to this AMA webinar on priorities and practical strategies for addressing well-being in Omicron's wake. We're so glad you're joining us this morning or this afternoon, wherever you are. This urgent webinar came together in record time from an idea that Dr. John Ripp emailed me about to execution and your attendance in 10 days. So we're so glad you're here to hear about this urgent topic. I'll start by introducing Dr. Ripp, who will then be our moderator and host for the rest of the hour. Dr. John Ripp is the Chief Wellness Officer at Mount Sinai Health System in New York. Dr. Ripp provides direction for system and individual level interventions designed to improve well-being for over 7,000 physicians and medical students and over 45,000 employees in the Mount Sinai Health System. In addition, Dr. Ripp is the co-founder and co-director of CHARM, the Collaborative for Healing and Renewal. And personally, I have the honor of being a co-faculty member with Dr. Ripp on a Chief Wellness Officer course held every year at Stanford. So welcome, Dr. Ripp. Take it away.
Thanks so much, and thank you, Chris. It's really a pleasure to be here. We can go to the next slide and get things started. I was remembering that I was here. You know, we had a webinar back in the spring of 2020. Are we able to go to that next slide? Move things along. Thanks so much. Yeah, so here's our agenda. We've already got our welcome off and running, and I'll share a bit more of what's coming after I give my brief introduction, and then I'll introduce our panelists, and we're looking forward actually to having a hearty discussion around this topic. If you can go to the next slide, and then we can keep moving through. So let me just pause here, give all of you a moment to read these objectives, to welcome you again to this webinar, and speak just a little bit about how we kind of thought about this. It was back in the spring, almost 2 years ago now, that we all really became introduced to COVID in full force. And it's kind of hard to believe how much time has passed, what we've all been through, how much experience we've garnered, and then more recently, what this Omicron surge has meant for so many of us. You know, there's been a pivot, I think, in terms of our approach to well-being, those of us in this space, as a result of COVID, and Omicron has highlighted that even further. That's what we're going to chat with you about today. You can go to my next slide. And so, you know, I think to start us off, clearly the issue around clinician well-being, physician well-being was nothing new prior to COVID. Many of you are probably familiar with this figure, which captures nicely how the consequences of burnout, as one potential measure of well-being, are both personal and professional. They affect the individual, they affect the systems and healthcare institutions that we all practice in. And so paying attention to it had become, you know, of critical importance before there was a pandemic. If you go to the next slide, you'll see that there was quite a lot of groups that were picking up on that before COVID. These are all kind of grabbed from you know, snapshots from work, from pieces that capture this. The interest that was seen amongst payers like CMS, which have put efforts into place to unload the burden on clinicians. Our electronic health record industry has taken note and has begun to act. And took note prior to COVID. Many of you are familiar with the National Academy of Medicine Action Collaborative. So that's where another high-level, high-visibility place that we see attention and have seen. And of course, the AMA has always been a staunch advocate of this work and really driving the field forward. So that was pre-COVID attention. If you go to the next slide. You know, I think it's fair to say that prior to all this, the literature, and thanks to folks on this panel and many others, helped the literature become robust enough that we had developed a number of models. There are a few out there that people look to in terms of our approach to well-being and the way in which we consider how to organize our measurement and our interventions and so forth. But I think one hallmark that kind of crosses multiple models is the impact, the emphasis, I should say, on the system. It's not that well-being or lack thereof or burnout is a function of having a deficiency in resilience. In fact, our healthcare workers, and particularly in COVID, have demonstrated themselves to be an extremely resilient group. It's about working in a system which unfortunately has worked to erode the well-being of that group. And so the models prior to COVID really put the emphasis on this. Next slide, please. So within the pandemic, we've seen yet new stressors emerge, not just those that have been highlighted before, where particularly the emphasis on the system, as I mentioned, looking at the way the culture of medicine or way the efficiency of the workplace contributes to well-being. These were kind of well understood. I think in the midst of COVID, we saw some new stressors emerge. And certainly, I don't know about you all, but I know that I can sense a change in my morale and mood as I watch the COVID numbers in my hospital system go up and down. And certainly we see different stressors emerge as at the beginning, at the top of this, you'll see that figure as numbers go up, there's a lot of fear for basic needs. How am I gonna get to work? How am I gonna care for my loved ones? Am I gonna get sick? I think we've seen in the pandemic the role that uncertainty has played in driving fear and anxiety, and that lends itself to ideas for intervention, that if uncertainty is causing stress, authentic, regular, transparent communications can unload that. And of course, as seen at the bottom slope of the upper figure there, and then in the figure below that I was first introduced to by one of our panelists today from SAMHSA, this figure shows that as the numbers come down, or as we emerge from response to communal trauma, and we have that period of sort of heightened intensity of work, well, in the aftermath, often there's disillusionment, there's opportunity to process experiences and grieve. And I think we're seeing that for sure, and can anticipate that. Actually, I would anticipate that in the coming weeks, we're going to see that a lot as Omicron wanes. Next slide. Certainly in Mount Sinai, in our data, we captured the psychological toll of COVID in a spring 2020 survey of some 6,000 frontline healthcare workers, just over half of whom responded, and we found that nearly 39%, nearly 40% had at least one symptoms of at least one of the following: depression, anxiety, or PTSD. Next slide. The AMA has done a lot of work to identify the impact of COVID on the workforce with their Coping with COVID data. Their survey of 11,000 nurses, APPs, and physicians, and this slide is courtesy of Dr. Sinsky, and you can see the reference of the work that she's been championing. We see the impacts on workforce desire to reduce work or leave the field, which is of considerable concern, and a number of risk factors that have emerged for that. Next slide, please. So here we are now. In fact, this figure is a month old now, but this is what we're experiencing with Omicron. We knew a lot prior to COVID. We've learned a lot in the midst of the pandemic in total. And I think the Omicron surge itself has highlighted a few very specific concerns that are going to influence the way in which we address well-being moving forward. So next slide. Much of this has been captured, and I think a spotlight has shone on this in the midst of Omicron in particular. We've been calling this the Great Resignation, where we've been seeing droves of healthcare workers leaving the field, and staffing shortages were a dramatic challenge as a result of the pandemic in general prior to Omicron. And then as Omicron hit and infected so many of our workforce members, leading to even more acute staff shortages, clearly this is an issue that we've seen as a result of this pandemic, which is going to remain well beyond, and something that all of us in the well-being space are going to have to contend with. Next slide. And so as a way of moving into our next speakers, I think that what prompted this webinar today is whether we need to reconsider a shift in our priorities. Those of us that are thinking about how to organize our efforts to think about well-being, to think about our approaches. You know, what have we learned from COVID? Certainly now more than ever, as we've seen from these data, the needs are great. Some other interesting information that has emerged, which one of our panelists will get to in some respects, is that pre-pandemic well-being efforts may actually enable institutions to better respond to the well-being of their workforce during crisis periods. There's some suggestion that in places where efforts were already evolved, that those places were able to perhaps more rapidly respond to the well-being needs of the community. And certainly those models that we spoke to, the emphasis on the system, I think remains critical, remains true. That's not going away, and certainly is going to be part of our priority list. The next slide just it gives a little bit of food for thought and helps launch us into our next few panelists. I mentioned what I think will be critical is the focus on retention and what can institutions do. What are there certain, if they have to act now, what can they do to enable a focus on retention and the drivers linked to it? You'll hear more about the toll that this pandemic has had on the mental health needs of the workforce. And I highlight here the Lorna Breen Foundation and their All In campaign, because many of us know that they've been a real champion, leading to a large amount of federal funding directed towards these issues, particularly the mental health needs. And then, of course, the new drivers that I spoke to, and some other issues that have emerged. I think when tensions have been running high, it influences that doctor-patient relationship. And so we're going to hear more of that. And so with the next slide, I'll use that to introduce our speakers. I'll introduce all three. This is the order in which they're going to be presenting. And I really am so honored and fortunate for all of us to be joined by them today. Dr. Lottie Derby is Professor of Medicine and Medical Education. She's co-director of the Program on Physician Wellbeing at the Mayo Clinic, and she's clearly a thought leader in physician burnout and engagement. Many of us are familiar with her work as really being foundational to our field. She'll be followed by Dr. Joshua Morgenstein, who's Associate Professor, Vice Chair in the Department of Psychiatry at the Uniformed Services University of the Health Sciences, where he's also Deputy Director of the Center for the Study of Traumatic Stress and an active captain in the Commissioned Corps of the U.S. Public Health Service. And finally, Heather Farley, who's Chief Wellness Officer for Christiana Care, where she oversees Christiana Care's Center for Work-Life Wellbeing, and is a model for many of us of being one of the early Chief Wellness Officers getting into this space. So with that, thank you for the opportunity to share these introductory comments. We'll hear from our speakers and then have a chance for discussion. Let me pass it along to you now, Dr. Derby.
Wonderful. Thanks a lot for that introduction, Dr. Ripps. We can go ahead and go to that next slide, please. So I just want to share with you some really recent data about the experiences of physicians. So this comes from a national study we just completed in a collaboration with the AMA and Stanford of over 6,500 US physicians. And it was done about 6 to 9 months into the pandemic. And that time we're really seeing that physicians were really commonly reported mistreatment and discriminatory behaviors by patients, families, and visitors over the last year. As you can see on the slide there, nearly a third had been subjected at least once to offensive racial or ethnic remarks, sexist remarks. 1 in 5 had experienced unwanted sexual advances from patients, families, and visitors. And 22% had experienced where a patient or their family refused them to provide care because of some personal attribute. Next slide, please. And as many of us would anticipate, we see that women physicians and physicians from ethnic and racial minority groups are much more likely to have these experiences of mistreatment in comparison to other physicians, after we control for a variety of other factors, including if you're in private practice or academic, what specialty you work in. And you'll also note that it's more common among the younger physicians, and that there were also big differences by specialty, with our physicians really on the front line working in emergency medicine having substantially higher odds of experiencing mistreatment and discrimination relative to other physicians. Next slide. And this is important because when we have these mistreatments, it increases our work stress. And as you would anticipate, the more mistreatment experiences physicians have, the higher likelihood there is for burnout. So here you see on the on the image there, as the frequency of mistreatment goes up, the prevalence of burnout goes up. And what you'll also notice from that multivariate analysis is once you control for the experience of mistreatment, we actually no longer see a gender difference. So women are no longer at higher risk for burnout once you control for the experience of mistreatment. It's just that women are having so many more mistreatment experiences. That's why they're often at higher risk. And the data that I was showing you in the previous slide is very much cross-sectional, right? Oh, here it is again. And there's always this sort of conversation around the chicken and the egg, right? But if we move into the next slide, I'm just going to show you two studies that have been published, one in graduate medical education, the other in undergraduate medical education, which are longitudinal. And here what you see is residents who report negative interpersonal experiences at work in the second year of residency. That's an independent predictor of them having burnout a year later in the third year of residency. And that's after you control for demographics, baseline burnout, depression, anxiety, and quality of life symptoms. So this is in a very large study of over 3,500 residents from all specialties across the United States. If we go to the next slide, that's a representation of another longitudinal study, again showing that experiences of mistreatment at work or in your learning environment as a student or as a trainee predicts the development of burnout as well as career regret in a big national sample of US medical students, even after you control for a variety of baseline factors. So this recently just published in JAMA Network Open. We can go to the next slide, please. And unfortunately, COVID-19 has really exacerbated violence, harassment, and stigmatization against healthcare workers. And here people are really doing their best, working extra hours, taking hard shifts, wearing PPE, and yet they're experiencing mistreatment from patients, families, and visitors. Next slide. And it's important that we take action to respond to that. So Canada has taken quite the action. They've actually passed a new law making it clearly illegal for people to bully, harass, or otherwise intimidate healthcare workers in person or online, and also making it illegal for people to impede access to medical facilities or intimidate people who are trying to access health services such as COVID-19 vaccination. The fact that they had to pass a bill making this illegal just tells you that the problem we're seeing in the United States is not an isolated one, but rather happening, at least in North America, quite frequently. Next slide. At Mayo Clinic, we're reacting to this experience that we're having here, just like everybody is having nationally, really through a variety of different ways. Part of it is really helping to upskill all of our staff and how do you address patients and visitors when their behaviors really are inappropriate. But also, what is the process and the rules around how can you dismiss or terminate patients who just consistently won't align with our values in terms of how we treat each other, and what's the processes for reporting that, and also how do you sort of deal with it when a patient makes a request to not be cared for by a certain healthcare professional because of their personal attribute. So these are all things that we didn't have in place when I started at Mayo 20 years ago, but these are things that we now have in place in reaction to what's going on between patients, families, and visitors and the healthcare worker. Next slide, please. So as we'll talk about today, and I'm going to pass the baton off to the next panelist, is that taking action to really promote well-being takes commitment, leadership, infrastructure, resources, accountability, and culture. And many of these tactics are summarized in the National Academy of Medicine Consensus Study Report, Taking Action Against Clinician Burnout, which you can freely download from the National Academy of Medicine website. If you don't want to read the book, there are cliff notes and a variety of other tools to really help you implement change within your local organization. So with that, Dr. Ripp, I'll go ahead and pass the baton back. Thank you very much for your attention.
Great. Well, it's good to be, do you want me to get started, John, or?
Yeah, go right ahead. You can go ahead, and then we'll go right to Dr. Farley afterwards. Thank you.
Sounds good. Sure. Well, it's good to be with everyone today. In the brief time I have, I'd like to remind us of a few important aspects of how disasters and other crisis events impact mental health that are particularly important for thinking about provider well-being, healthcare worker well-being, and operational sustainment, and also highlight crisis leadership actions that strengthen organizations and foster recovery. Next slide. These are my thoughts and ideas, and I have no disclosures or conflicts of interest. Next slide. When we think about stress on the healthcare workforce over the past 2 years, it's really been the collision of multiple disasters that have pulled at the fault lines in our communities. And these kind of things exacerbate divisions around issues of race, socioeconomic status, religion, and other areas. And when we add this to restrictions and altered home and work life related to the pandemic, the experience has really left many people feeling particularly isolated and disconnected in unique ways that many disasters do not. And of course, healthcare workers have also experienced a wide range of unique stressors inside of this environment. Next slide. In disasters, the psychological and behavioral impacts are the most far-reaching and long-lasting, with many disasters producing a lengthy tail of mental health effects. And we should be alert to this in COVID-19 as well. When we think about mental health and disasters, we often talk about psychological disorders like PTSD and others. And these are certainly important, and we have good treatments for these disorders. But in order to really protect health, we need to also be aware of other outcomes of concern that we don't think about or talk about as often, but are much more common than disorders. Distress reactions and health risk behaviors, these kind of things cause significant public mental health burden and negatively affect healthcare workers. And they're often associated with higher rates of things like work errors and presenteeism in the workplace, accidents, and even community violence. So it's important that our interventions address this broader range of distress and risk behaviors that can diminish our well-being and negatively affect our personal and work lives. And of course, it's critical to acknowledge and address the difficulties people are experiencing, but it's also good to remember that the vast majority of people, including those who experience difficulties along the way, will ultimately be okay. And some people even experience an increased sense of their ability to manage future stressors. This can be an important message for us to keep in mind and even to share with others along the way. Next slide. Stress occurs across a continuum, and this becomes particularly important when we think about the issues of who and what and when with respect to risk and interventions in COVID-19 or any other high stress event. Many systems focus heavily on the extreme ends of the continuum, where personnel have to rely largely on either self-help or mental health treatment. And though some people will engage in self-help behaviors, that isn't sufficient to maintain well-being in a disaster or any other crisis event. And many people won't use clinical mental health care, in part because of stigma and concerns about career implications, but also because that's not really what they need. During crisis events, most of us spend much of our time somewhere in the middle areas. And this requires a broader range of policies, practices, and procedures, as well as an organizational culture in which all personnel play a role in fostering community well-being. Next slide. There are really 5 essential elements that protect health during extremes of stress, and those include enhancing a sense of safety, calming, efficacy, social connectedness, and hope. And these elements form the basis of what's been called psychological first aid, which is an evidence-based framework for supporting resilience in individuals, communities, and organizations. This slide lists interventions that have an evidence base for protecting well-being of healthcare workers during a prolonged crisis, such as a pandemic. And some healthcare systems have actually adapted these and other practices from various high-stress occupations to foster resilience in their workforce during the pandemic. So as we think about interventions, we want to remember that protecting health and sustaining operations requires actions by individuals, but also organizations and leaders. So I'll briefly highlight a few principles and practical actions to help leaders support their communities. Next slide. Some of you are leaders, will be thrust into leadership positions and may even be advising leaders. And leaders exist at many levels, including team leaders, charge nurses, service chiefs, department heads, and others. What leaders do and say during times of crisis has an impact not only on the well-being of personnel, but the trajectory of recovery for a community. Leader isolation has become a particularly significant challenge during the pandemic. Many leaders have been hunkered down for a long time. So finding ways to connect with individuals and teams is an important leadership action to help leaders take the temperature of the team, better understand individual concerns, and also to learn how best to support people. Next slide. I was reminded about the impact of leadership behaviors during our work with the National Guard. In our sample of roughly 4,000 military personnel, higher levels of leadership support were significantly associated with better mental health and overall health, with better sleep and less alcohol use. Specific actions that were associated with higher levels of perceived leadership support included praising people for the good work they were doing and reminding people that the work they were doing was valuable. Next slide. Grief is a near universal aspect of disasters and one that's often overlooked. Healthcare workers and many others are grieving now and will continue to be grieving in their occupational lives and their personal lives. Grief over loss of routines, feelings of safety, certainty about the future, the lives of patients, colleagues, and family, and for some, even a sense of hope. The term grief leadership was coined by Dr. Colonel Larry Ingram from the Walter Reed Army Institute of Research following the US military air disaster in Gander, Newfoundland in 1985, which killed all 248 soldiers as well as the crew on board. This was the deadliest peacetime military air disaster in history. And communities in which grief leadership was utilized actually recovered more quickly. So effective grief leadership fosters healing and recovery through genuine and ongoing communication by openly acknowledging and addressing issues of grief, facilitating processes that honor losses, helping to make meaning of the event, and then finding ways to look hopefully to the future. Next slide. It's helpful to remember for leaders and for all of us that hope isn't something we just wish for. It's something we create. So the kindness we extend toward others and even ourselves, holding in our minds a picture of what any person, whether it's a coworker, a friend, our child, what that person can be, and not just who they are in a particularly difficult moment. These are the thoughts, the words, and the actions that build a sense of hope in the future. Next slide. We'll look forward to our discussions, and I'll end there and turn it over to my colleague.
Josh, there's a lot that you talked about that there'll be some overlap in what I'm talking about next. And so that was a great segue. And I really love that hope is an action. I'm going to take that with me. Thanks for sharing that. So I'd like to start actually by sharing an excerpt from a social media post that was, this was posted by a fellow emergency physician. If you can go back to the previous slide. There you go. Awesome. Thank you. So this emergency physician posted this back in March of 2020. So right at the beginning of the pandemic. I'm scared too. I'm scared that when I go to work in the emergency department and start seeing the wave of patients that are coming in with this virus, I won't be able to help some of them. That I'll have to make decisions who will get a ventilator and who won't. That my own health and safety will be compromised because I won't have the right equipment to protect myself. But guess what? I'm still going to go to work. I'm still going to do the job that I spent 11 years, $300,000 and my youth training to do, because it's my duty as an emergency physician to use my skills and do what I can in a time of crisis. Please support us because we're about to go to war for America with COVID-19. And that strikes me because 2 years later, we are still at war. Health systems are in crisis and the circumstances are more dire than they ever have been. And health system leaders are in a bad spot too. They're struggling right along with us. They're managing way too many priorities. And when it comes to thinking just about clinician well-being and burnout, they're bombarded by too many different messages from too many sources. There's lots of great, robust resources out there on long-term solutions. But I think what we need right now is a succinct, tactical, urgent list of actionable strategies that health systems can take in the short term. Next slide. Next slide, sorry. So to that end, a diverse group of healthcare key stakeholders were convened to create a list of top 5 actions that health systems should take right now to coordinate those efforts across our respective organizations to send this unified, succinct message out to health systems. So this is hot off the presses. We just finalized our list at 10 a.m. this morning, so the ink is not even dry, and you are all the first to see this. So we've titled this list, next slide please, the 2022 Healthcare Workforce Rescue Package. This resource is going to be housed on the All In for Healthcare website. There'll be free access to everyone. On that website, we'll have a brief explanation of each of those top 5 solutions and links to some actionable resources. There'll also be a downloadable PDF there. The design for this is still in progress, so bear with us with that. Next slide, please. So the audience for this list is, the primary audience is US health system executives. Our secondary audience is frontline clinicians. We hope that they can use this list as an advocacy tool with their local leadership to foster action to promote well-being. A note that the recommendations that we included are evidence-based. We focused on system interventions rather than individually targeted interventions, and we emphasized actions that can be taken during a crisis. All right, so let's dive in. Next slide, please. Our first recommended action is, these are non-normal times. Adjust expectations. The ultimate goal here is to get alignment between the frontline and healthcare leadership and really the entire team to reduce demands and increase resources. That seesaw between, that balance between demands and resources, as we know, is way out of balance. So the thought here is to give clinicians more flexibility and autonomy by using crisis documentation protocols, for example, or adjusting our quality and patient experience goals. There is no way that we can expect our caregivers, our frontline clinicians to perform at the same level now when there are less resources than there ever have been in general. This move has actually been a game changer for our organization. So prior to this, what we were sensing was that the lived experience of our front line was that the house is on fire, but the rhetoric that's coming out from leadership, both internally and externally, didn't necessarily match that. And a couple of weeks ago, our health system just implemented crisis standards. And that move really helped get us all aligned and removed some of that cognitive dissonance. And it's been really powerful. So we're now have that sense that we're all rowing in the same direction. Next slide, please. The second recommendation is to get rid of stupid stuff. So hopefully you've heard of the Get Rid of Stupid Stuff campaign. If you haven't, when this does go live, you'll be able to see some links with some really easy to use resources to start getting rid of stupid stuff. This is the thought behind this is to partner with clinicians to identify and remove low value work through a rapid improvement process. Things like reducing EHR clicks for common workflows, minimizing inbox notifications, and eliminating unnecessary mandatory training requirements, so clinicians can focus on that critical task of patient care. Next slide, please. The third recommendation is get radical to shore up staffing. And we know we need to get that front line the help that they need. Ways that we can do that, sending executives to the bedside so they can see what it's really like and to pitch in and have that sense that we're all in this together. Consider voluntary redeployment for non-clinical staff to the front lines. Creating new types of shifts to fit care needs. Maybe we have 4-hour shifts where someone's just putting in IVs. And finally, training and upskilling nurses, LPNs, and MAs. Next slide, please. The fourth recommendation is designating a well-being executive. In my health system, we've had a chief wellness officer. I've been privileged to be in that role since 2019, and I've got a team that works on this. But most health systems don't have that privilege, and I cannot imagine what they're going through right now. What they really do need someone who's in charge of coordinating all of the disparate efforts around it, trying to improve the well-being of the frontline caregivers. So appointing one person with the operational authority to oversee and align all of these clinician well-being efforts. Ideally, that would be a system chief wellness officer. If that is not feasible, at least assigning a senior leader on a short-term basis until long-term resources are identified. Next slide, please. And finally, EAP or employee assistance programs are not enough. We know that, right? And so we're really urging implementation of what we're calling the foundational 3, providing quality mental health counseling and reducing barriers to help-seeking behavior. Standing up peer support programs. This has been an incredibly effective strategy in our organization. At the acute phase, the first phase of the pandemic, we actually saw a 3-fold increase in one-on-one peer support encounters and a 10-fold increase in group peer support sessions, which was an incredible uptick. It really was a foundational component of our support infrastructure. So this is, I think, one of the most important pieces on this one. And then finally, Josh mentioned this, offer psychological first aid training for all people leaders. This is not expecting our people leaders to be counselors or therapists, but really equipping them so they can recognize when someone on their teams is struggling, that they can respond effectively and help get them connected with effective resources. Next slide, please. So what's next? Well, we want to get this into the hands of every leader and every organization. So each of the collaborating organizations that I mentioned at the beginning will undertake an email campaign to their respective constituents. Press releases will go out, and we'll also employ a robust social media campaign. And then we'll also be hosting podcasts and other venues of engagement so that we can dive into each of these recommendations in more depth. Ultimately, we hope that this starts a robust discussion at many health systems, and most importantly, prompts meaningful action that restores that balance between the demands and resources for our healthcare workforce. Back to you, John.
Great, well, wonderful. Thank you so much to our panelists. A lot to unpack there and think about. Before we get going, I want to remind, I know there are quite a few of you watching today, so please do use that Q&A function to send in any questions you have for our panelists. And maybe I'll just get us started with a few questions to begin our discussion. And please do, for those of you watching, send in what questions you have. We want to hear from you and keep this engaging. So let me start with a question for each of you, and maybe you can just answer it in the order with which you just presented. So Dr. Derby, then Dr. Morgenstein, and Dr. Farley. You know, in light of what we've just heard from you all and what we've been thinking about with COVID and specifically Omicron, what in your view, what in your opinion has changed, and what's the same or similar in terms of an organized approach to addressing clinician well-being, and how do you know these events of perhaps the most recent events with Omicron or the events of the last couple of years influence your thinking in that matter? So, Dr. Derby.
Yeah, thanks, Dr. Ripp, for that question. I think that strategy has changed, is changing, and probably needs to change even more. You know, our healthcare workers have been working tirelessly for, over 2 years, and some are running out of or getting thin on compassion. And we're starting to see some professionalism lapses. And I think we really need to approach that with our biggest heart and our greatest compassion, rather than with, more punitive lens. People are burnt out, people are tired, people are frustrated. I think particularly taking care of patients who have not been vaccinated, it's really starting to cause a lot of stress on our healthcare workers. So, leaders really need to continue their efforts to really improve the system, to build meaningful support and recognition, and then to have compassion, not only for patients and families and visitors, but also for the healthcare workers at this point.
Thank you. Dr. Morgenstein, your thoughts?
Yeah, I appreciate Dr. Derby's comments. For sure, particularly a reminder that at times and under extremes, the experience that people have of distress can sometimes even look like misbehavior. So being angry and being fearful can cause a lot of behaviors that one might not typically expect or might not interpret properly as anger and fear. And those are things we really need to be helping healthcare workers with. I think that, self-help and mental health care are certainly important aspects of well-being and a continuum of care. but they're not sufficient to protect healthcare workers and the healthcare workforce during a disaster or any crisis event, and perhaps not even during, they may not even be ideal by themselves during the normal stressors of daily operations. So maintaining the well-being of healthcare workers, certainly during crisis events, requires policies, programs, and practices that provide interventions across the stress continuum. And I think in a similar way, our overall approach to healthcare worker well-being should be built upon a culture that values and incorporates actions, not just of what individuals need to be doing, but what organizations and leaders can do in a way that's informed by the principles that we know are protective of health during times of crisis. So, imagine if every physician, just as an example, were trained during residency on those 5 essential elements we talked about earlier, and some practical actions to implement those in a variety of settings, maybe even with patients in distress, or to support their peers, or to foster their own self-care. What if every chief resident were offered training in essential principles of crisis leadership? This would really seed the healthcare system with critical knowledge on how to promote well-being in healthcare professionals across a range of stressful events.
Thank you. Go ahead, Dr. Farley.
I think for me, I'd like to focus a little bit on what hasn't changed. And, I think those of us who have been steeped in well-being research and setting up well-being programming, the foundational approach that we use is really, by not focusing just on personal well-being or personal resilience. That is absolutely important, but as we know, healthcare professionals are some of the most resilient people on the planet to begin with, and so asking our health systems, they really should be focused. All of us should be focusing at an organizational level on the environment surrounding the healthcare provider or the healthcare worker. So, going back to a frequently used analogy of the canary in the coal mine, that you can't take the canary, teach it to be more resilient, and stick it back in the same coal mine and expect it to survive, right? You actually have to change the coal mine. So I really feel like that is the thing that is more important now than ever. We each have our individual responsibility to focus on our own personal well-being, and our organizations can and should bolster the resources to help us do that. But I think an even more powerful approach is really focusing on that environment, the culture of well-being, and the efficiency of work, and much of what we covered today.
Wonderful. Thank you all for answering that, and lots of great questions coming in from the audience. So I think what I'll do at this point is shift to hearing from our folks who are watching, so we can try to benefit from your expertise as it relates to their specific questions. So one that comes, I think I'll direct to you, Dr. Morgenstein, but certainly our other panelists can chime in. Speaks to the recent recommendations from the CDC, the crisis mode staffing, and the advice to have healthcare providers who are sick with COVID and symptoms to go to work. I presume the audience member to go back to work after a short period of time. Is that in contradiction to self-care? Does that send a message that we are superhuman or expendable? And what can hospital leaders do to support providers when the CDC is releasing these recommendations?
Sure. Yeah, I do think that there is, from early stages, certainly I can speak for the physician side of things, a message that physicians are really able to just sort of take it and keep going, and a lack of awareness of what exposure to extremes of stress may do and the impact that it might have. I think it's an interesting question about the message about being superhuman and what those expectations are. It would be ideal for leaders to talk with and assess and better understand what's happening, what the needs are of their healthcare professionals in their system. So, I mentioned earlier this challenge of leaders being isolated. One of the most powerful things people can do is walk around and talk to their people. You'll learn things that you'll never hear in a survey or a focus group or an interview or anything like that. And so understanding what healthcare workers need in any given system, because there's no one size fits all solution. certain healthcare workers may need certain things at certain times. And that's one of the big challenges. Everyone's so busy and so stressed right now. But I certainly appreciate the question and the idea that leaders would be ideal for them to be tailoring how they approach those sorts of recommendations. And they are just that, recommendations, to the unique needs of their community and the groups that exist within that community.
Yeah, thank you for sharing that. So here's one, and again, if the other panelists want to chime in, please just give me the nod. But in the meantime, here's one for you, Dr. Derby. Can you share a success story or an anecdote where a physician or other clinician was supported by the system after an episode of mistreatment, perhaps as a way for us to frame some of these models you share with us of looking forward and what we can do to address this issue?
Yeah, thanks for that question. It is really a challenge, and here in Minnesota, we haven't commonly experienced patient mistreatment, harassment issues. So it's really rather new over the last several years. And in response to that, we have rolled out a variety of strategies, particularly with our teaching faculty, to really help equip them with the language and the approach to deal with it when there is mistreatment that's witnessed by a patient, family, or visitor toward a resident or a medical student. And I'll put the link in the chat to a couple of publicly available Take 5 videos. And they're just these short, succinct videos that have really these 5 pearls for how do you deal in the moment when you see, a patient exhibit an ism toward a medical student or resident. I think, in my experience, the first thing is don't panic and take a deep breath, right? Because you're like, what just happened? And the second is to be careful not to make assumptions and to be compassionate. What I found in the moment is actually it can be helpful to explore the patient's beliefs or demands. And then after that, to really set the expectation or what are the values and the culture of inclusivity within the organization, and why do we feel that behavior isn't, really appropriate or can't be tolerated. And if the offensive sort of comments and direction kind of continues, then, it's important to escalate the issue and bring it to the attention of leaders. So, we've really found it necessary to kind of upskill ourselves in how to deal with these episodes in the moment. And I can put that, there's a couple of different short videos that I can put in for a resource. One is really about how to support a learner when there is a patient bias. And the other one is around how to support a learner when a patient refuses to be cared by them because of a bias. And hopefully that'll provide some concrete tips and tools for the audience.
Thank you. Those sound like amazing resources. I personally want to look at those, so thank you for sharing. Dr. Farley, here's one that I think might be good for you as it relates to some of the work you've shared or the project underway that you've been involved in. Can you address the challenges of implementing systemic and cultural shifts in our smaller healthcare systems? You kind of made mention of this. That are struggling to balance funds and resources, places that might be less robust than those available to your systems. And this kind of gets at the question, does it require a CWO, a Chief Wellness Officer, to get the work done? So what do you think about that, Dr. Farley?
Great question. I have to say, having an operational leader focused on this certainly makes it easier, but it's not necessary. There are so many things that it's not necessary to make sufficient and meaningful progress. I think it is ideal to have that one person assigned. But there are so many things, and when we created this rescue package, that was actually the thought behind this, is we know that there are so many health systems that don't have those resources. And so what's in that rescue package are things that are meant to be realistic and doable for organizations without those resources. For example, even some of the Get Rid of Stupid Stuff campaign, that can be, those efforts can happen at a local level, at a departmental level. You can look at what is impacting your clinicians there and identify some of those pieces that can be removed. Other examples, like standing up a peer support program, it does sound like a heavy lift. And to do it, I think there are, for example, when we set our peer support program up 6 years ago, we had no FTEs for this. So it really was a labor of love on the side. And all of our peer supporters are volunteer. So we're not paying our peer supporters, and it is possible to set up a really effective peer support program that does not require significant additional resources. There are also lots of creative ways that people are trying to bridge that gap by implementing battle buddies, for example. So I'd encourage you to take a look and look that resource up as well. So there's some short-term things that people can do that organizations without that resource can absolutely get started that make a big difference.
John, can I piggyback on Heather's comment?
Please.
Yeah, so I appreciate the reference to battle buddies, a United States Army concept that I've had a lot of conversations with different organizations about adapting and implementing in their own healthcare systems. And as Heather mentioned, it sounds like her system already has their own peer support program that they've adapted. Massachusetts General and University of Minnesota both have buddy programs, and I think they both refer to them as battle buddy programs. The University of Minnesota's really started at the very beginning of the pandemic, and Massachusetts General a little bit into the pandemic, but Minnesota actually has a lot of their resources online. Peer support programs are really underutilized, and I appreciate Heather's comments and the incorporation of that type of a resource into the plan that she's implementing. But certainly people can find those resources online so they don't even have to reinvent the wheel. It's nice to be able to borrow things from people, particularly during times of crisis.
Yeah, thank you for sharing that. It's a great offering, and we also advocate it as well and use it in various ways. Dr. Derby, here's one that I think might be good for you as it relates to, sort of somewhat related to your content. Well, it starts off speaking to hospital vaccine mandates and the lack thereof for healthcare workers in hospitals, and how that's perhaps led to some divisions among healthcare workers, adding to daily distress in the workplace. Obviously, there's that impacts also patients who are vaccinated, not vaccinated, and maybe influencing that doctor-patient relationship, or having some impact on the mistreatment that you've been studying. What are your thoughts about that, about those, and sort of how those mandates can the impact that they may take, perhaps as it relates to some of your work?
Yeah, I think that's it's a great question, and it is very complicated, and it's all become so very political. You sort of think back to when the polio vaccine, for example, came out, and even though it was a live vaccine and some people got very sick from it, everybody just went to the school gym or went to the church and took it. And it really, eradicated polio practically across the world. And we're not having that experience with COVID-19, unfortunately, even though now there's good vaccine supply, at least in the United States. There's a cohort of healthcare workers and non-healthcare workers who, are unfortunately reluctant to take that vaccine. And that has created, I think, a big divide. And as I alluded to, has created some challenges with healthcare workers who are just getting exhausted at the end of their rope to continue to be compassionate toward patients who've not gotten the vaccine, but yet are then in the ICU, in the hospital, many of whom are dying, and that is causing very difficult situations. So, sort of what's the best solution to that? Hopefully people can feel more reassured about the safety and the efficacy of the vaccine. I think the best way to stop Omicron version 2.0 or Omicron Delta, viruses for more people to get vaccinated so that ultimately we can end the pandemic and get it under better control and go back to all the things that we used to do, which includes a lot of, as we talked about, this social isolation has really, caused a lot of loneliness, and that exacerbates our risk for mental health problems. We're definitely seeing that across the United States. Depressive symptoms are up about 4-fold, suicidal ideation is up about 2-fold, and that's in the general population. So I think it's time for all of us to really get together and work collaboratively to end the pandemic.
Thank you so much. I'm going to try to sneak one more in for Dr. Morgenstein and one more in for Dr. Farley before we have to wrap up. Dr. Morgenstein, a question came in. What should we be preparing for in terms of how best to memorialize and honor the service of our workers? And maybe you can fold in there also thoughts about what grief leadership and practices that leaders can include to foster well-being as we recover.
Yeah. This is a conversation that's going on at a national level and even global level through different organizations and international entities. And so memorialization has, after disasters, has sort of an interesting history to it. And there's certainly a lot of practical lessons that we can learn and look back to how we memorialize things like wars and other terrorist events and other things. I think one of the real challenges that we're going to have, particularly on a large scale, efforts to memorialize on a large scale, are the fact that this disaster, more so than many disasters, has divided society. And so the idea that there is something to memorialize bespeaks one's position and perspective. There are people who do not agree that there is something to memorialize. And so I think that will complicate efforts, both frankly at a national level, but even in local communities, and that we're likely to see the same divisions around the issue of memorializing. One of the most central tenets to issues of grief leadership, and I think extends to memorializing, is the idea of involving the community. This is always more challenging because more voices equals more conversation and more disagreement. But in the end, and for leaders who are looking for ways to figure out how to memorialize even inside of their own group or smaller community in a healthcare system, perhaps a colleague passed away or some other untoward event happened inside of a healthcare system, the idea that leaders have to figure all this out alone is antithetical to grief leadership. It really is important for people to be involved, because then you understand what they need, but it also gives people a feeling of efficacy, that they can be involved in the process of memorializing something, and that in of itself is often healing for people. So I think if there was one thing I would encourage leaders to do as they are thinking about issues of grief and attending to issues of grief, it's to not feel compelled to do this alone, which is something that certainly physicians and many other healthcare professionals often feel like, I got to just go figure it out. Bring other people in, listen to others, and let everyone be involved as a community.
Thank you so much. Such sage advice, and really highlighting both how complex it is, and also that despite it sometimes being quote unquote lonely at the top, there are others that you can lean on and as part of your community of leaders. Dr. Farley, I'm going to try to fold in a couple of questions to end with you on, one of which is about, one of the efforts there talked about these times are in your top 5, times are not normal to adjust. So maybe you could speak to crisis standards of documentation, something specific perhaps that has changed, and whether this, your effort overlaps with other efforts like the National Academy's recent resource compendium or any other national groups. How does your work complement that of other groups?
Absolutely. I actually answered the National Academy of Medicine question in the chat. It does definitely overlap with the recent compendium that the National Academy of Medicine released. So this was meant to be a synergistic effort and pointing back to many of the National Academy of Medicine resources, but really highlighting the pieces that are tactical and actionable on the short term. So that's how those kind of fit together. In terms of crisis documentation standards or just crisis standards in general, and that shift in expectations, that how that's played out for our organization specifically. A great example is releasing the nursing documentation standards. So here's how we do it in normal times, and here's how we're doing it right now. And the expectation is that our nurses are focusing on clinical care, and the documentation happens later. So if they were previously expected to document vitals Q2 hours, now they don't have to document it until Q4 hours. They have to provide the same care, as much as possible, but the documentation goes to the wayside and is secondary to their need to provide clinical care. Other shifts that we've had, I think, that have lightened the load for our clinicians include turning off some of the alerts around patient relations complaints. So it doesn't mean that we don't have an expectation that we treat our patients compassionately, but the alerts that we are getting on a frequent basis, we're toning those down. We're also, turning off a lot of the communications about documentation deficiencies to our clinicians, and also pausing some of the mandatory training requirements right now. So that's a few key examples that I think has really helped to have our physicians, our nurses, our other clinicians know that we get it, and we're going to do the best that we can as an organization to lighten the load.
Such great ideas, small things that can really add up to make a difference. Thank you for sharing that. And thank you to all the panelists. It's been a really robust, an interesting discussion. I feel like we could have gone on for another hour, but I do want to be mindful of time and pass it back now to Dr. Sinskey to close us out. Thank you again.
Well, thank you everyone for joining us, and thanks especially to Drs. Ripp, Derby, Morgenstein, and Farley for sharing their knowledge and experiences with us. We have a lot of resources. I've put many of them in the chat. You will get an email with a link to this presentation that you can share broadly in your sphere of influence, and you will get some of the specific resources that we have. But we do have over 20 podcasts, over 40 webinars, and over 70 practical, actionable how-to toolkits to do anything from setting up a peer support program to creating a program that's meant to be provide psychological first aid. So with that, thanks everyone, and have a good day.